Welcome to the ACP Problem Solving in Oncology webinar series, and tonight's topic is breast cancer. We're very lucky to still have Dr. Cliff join us this evening, and she's going to speak to us about breast cancer in pregnancy. So I'm going to hand over to Dr. Cliff. So Dr. Cliff is a consultant medical oncologist at the Clatterbridge Cancer Centre in Liverpool, and is a very keen educator. She's actually our training programme director as well. And so Dr. Cliff did her medical training at the University of Liverpool and trained at the Clatterbridge Cancer Centre as well, and then did her MD in chemotherapy-induced peripheral neuropathy. But tonight she's going to speak to us about breast cancer in pregnancy. So I'll hand over to Dr. Cliff. If you can please share your slides. Thank you.
So I'm Jo Cliff. As Jenny says, I'm a consultant in medical oncology up in Liverpool. I think there's been a slight change in the topic. I think initially Jenny was thinking of pregnancy, and then I think it got changed to a more broader breast cancer in young women. So it's quite a lot to cover in this. We will touch a little bit on pregnancy, but there's probably a little bit too much in the whole topic to focus down loads on pregnancy, but hopefully this will give you a flavour of some of the issues when looking after particularly young women who present with breast cancer. Of the issues facing breast cancer in young women, and for many of the guidelines, young women is defined by presentation at less than 40 years. And most of there's many of those images that are common to women at any age when they're presented, unfortunately, with a breast cancer diagnosis. But there are some additional issues that do affect particularly young women that are over and above those that we're more used to dealing when we're dealing with women, particularly postmenopausal ladies with breast cancer. So I've just kind of done a bit of a thought map of some of those issues that go alongside a diagnosis of breast cancer over and above their primary treatment, which of course we're all used to training in and learning about and offering the correct treatment in terms of systemic anti-cancer therapy following an early breast cancer. Under the age of 40, breast cancer remains relatively uncommon, and it accounts for only about 5% of new cases of breast cancer. But I still think that although 1 in 68 isn't huge compared with the frequency of breast cancer, when you think that 1 in 68 women will be affected by breast cancer by age 40, I still think that sounds quite a lot. I relate that to going and standing in my school playground to pick my children up and thinking, actually, that's probably one woman in every primary school playground waiting for their children who will be affected by breast cancer whilst they're still very young and still at a point in their life that often there's lots of activity with work, family, which adds additional pressures to perhaps those that are diagnosed in later life. It is also the most common cause of cancer death in women under the age of 40. Additionally, survival rates are lower in the younger population than in older women with breast cancer, and this is multifactorial. A lot of it's probably driven by the pathology of the breast cancers that we see in a younger population. There's less ER-positive HER2-negative disease, far more triple-negative, more HER2-enriched breast cancers. But even within that, the patients that do develop luminal A-type breast cancers at a young age also seem to have a poorer prognosis than those women who develop luminal A breast cancers in older age. Another factor that may drive the poorer survival rates is that there's probably a tendency for women at a younger age to present at a later stage, with very few of the population under 40 being regularly screened. And the only people who are likely to be within a screening programme are those already known to have a familial susceptibility, either through genetic screening or through family history clinics. An additional issue is that younger women are often underrepresented in trials. So we haven't got as robust data as in the more commonly affected age groups when we're looking at the evidence for particularly young women who are diagnosed with a breast cancer. As you can see from the beginning, one of the beginning slides, where I just kind of mapped out some of those those issues that perhaps have a greater impact on younger women, and some of those additional issues. I'm never one who particularly likes to just go through a whole list of slides outlining all of those issues. I'd much prefer to talk about some patient stories. I hope that format is okay, but hopefully along the way we'll pick up some of those issues and perhaps expand a little bit on those topics that are of relevance in this younger population. So the first lady is a 33-year-old woman who I met a few years ago. She presented with an inflammatory breast cancer of the right breast, which was grade 3, ER positive, PR positive, and HER2 positive. Clinically, up front at her breast assessment on ultrasound, it was clear that she also had nodal involvement as well. On assessment with MRI, she also had DCIS in the left breast. So when we see her, obviously, we're oncologists. Our first thought is, what are we going to offer in terms of treatment? This isn't a lecture about the treatment of ER positive, HER2 positive breast cancer, so that's straightforward. We're going to we want to give her some neoadjuvant chemotherapy. And yes, we gave her AC, docetaxel, trastuzumab and pertuzumab, but equally she could have had an anthracycline sparing regime. But she's 33. So we've got additional issues that we need to deal with when we're meeting her to ensure that we actually provide good quality, holistic care. We need to think about fertility. She's with a partner, relatively serious partner, but they haven't got any children. We also need to think about genetics. She hadn't got any relevant family history, but she's very young to have both an active breast cancer, but also DCIS in the contralateral breast. And we need to think about whether she's at risk of a genetic susceptibility. So thinking about fertility, this is a very busy slide. The upshot is that when this is a fairly recent study looking at the rates of treatment-related amenorrhea, everyone who's treated breast cancer will know that for many women who we give chemotherapy to, they do get temporary amenorrhea, but actually for many women, periods and potentially fertility does come back. But of course, there's no guarantee that that is the case. So the consultation needs to look at what the chances of infertility are. And this doesn't tell us about fertility, but it does give us some idea about the risk of premature ovarian failure. I'd particularly look at the second table, which looks at the rates of 2-year treatment-related amenorrhea. So this is more persistent amenorrhea in the under 30s, age 31 to 35 and 36 to 40. If we look at the bottom at all regimes, and this summarises some of the most commonly used regimes that we would use in practice currently. And we can see that there's about a 10% rate of persistent amenorrhea at 2 years in the under 30s, rising to about 23% in the 36 to 40 age group. In addition to premature ovarian failure, even if periods come back, we know that even if fertility might return, those women who have been exposed to chemotherapy are more likely to then enter a menopause at an earlier stage. So we need to counsel about those risks. And with that, address the potential fertility considerations. Now, this woman, when she presented, I think was less bothered by her breast cancer and more bothered by the fact that this was going to mean delaying childbearing. She'd reached a stage in her life where that is what she wanted to do. Her and a partner were looking at really settling down, and perhaps childbearing was not that far away for her. So this was a cause of real psychological and emotional distress. So we did a rapid referral into fertility clinic, and the main options are for preserving fertility that are well evidence-based are embryo cryopreservation and egg preservation. If a patient is in a stable enough relationship to be able to undergo embryo cryopreservation, this is preferable and results in a higher chance of those preserved embryos resulting in a live birth. There is a smaller chance with oocyte cryopreservation, but for many women presenting at a very young age, they may not have the stability in a relationship to allow them to go under IVF with a partner. I've added ovarian tissue cryopreservation. My understanding is still at this time, under NICE guidelines, this isn't funded. There are some programmes within the UK looking at this measure as an alternative form of fertility preservation. And the advantage of this, particularly in a breast cancer setting where we're wanting to get on with treatment, is it doesn't require quite the same level at all of ovarian pre-stimulation. So it can be turned around a bit quicker. She was in a situation where they'd looked into things privately and actually was able to access a programme that was offering this on a kind of trial basis in London, and her CCG actually offered to pay for this. So she chose to go for ovarian tissue cryopreservation, which actually in her situation with an inflammatory breast cancer did mean that everything could run very quickly. From me seeing her on a Tuesday, she was down in London by the end of the week, and we were starting treatment the following week. So it all ran incredibly smoothly in that respect. In addition, there is some evidence of looking at ovarian suppression during cytotoxic chemotherapy. There's been a number of trials in the background that have looked at whether giving goserelin during chemotherapy could potentially increase the chances of periods returning after cytotoxic chemotherapy. There is now data on a meta-analysis level, both a Cochrane review and a further meta-analysis that was published in the JCO in 2018, which confirms that we do believe that it reduces the risk of premature ovarian insufficiency without compromising breast cancer outcomes. So in the latest iteration of the ESMO guidelines for treating cancer in young women, this is recommended as a further measure for women who wish to preserve fertility. However, what the data doesn't show is, yes, we can see that the rates of resumption of periods are higher, but we haven't got the evidence to say it definitely preserves fertility. So this is an alternative to embryo or oocyte cryopreservation, but may add an extra layer of help along the fertility and route, potentially alongside chemotherapy, with, on the face of it, no detrimental effects to cancer diagnosis. So this is something that this lady wished to pursue, so we gave this in conjunction with her neoadjuvant chemotherapy. The next added consideration is genetics. We know that younger women are far more likely to harbour a genetic variant which has put them at higher risk of developing this breast cancer. The National Genomic Test Directory is almost like the cancer drugs list for genetics. This is updated regularly and takes into account updates as to the guidelines as to what can be tested for who. This was updated last year and actually now includes all women with a breast cancer diagnosed under the age of 40. Some of those additional criteria haven't changed. Breast cancer below the age of 45 with a first degree relative also diagnosed under the age of 45, triple negative breast cancer under the age of 60, and bilateral breast cancer under the age of 50. All male breast cancer patients and those with a family history strong enough that they're getting higher risk scores on Manchester scoring or CanRisk score tools are also eligible, as are those with Ashkenazi Jew ancestry with a breast cancer diagnosis. But as we can see, many of these women, all of these women now under the age of 40 are eligible for germline screening. We're now doing this as part of a mainstreaming project, and I think that's happening more throughout the country, that in some areas that will still mean a referral to genetics. In other areas, either breast surgical teams or breast oncology teams are doing the testing for these more sort of straightforward eligibility criteria. The panel includes these 7 genes which are reviewed. Obviously the really high risk genes, BRCA1, BRCA2 and PALB2, and then some of the more moderate risk genes also are now tested as part of that panel. There are a couple of special groups that, even if there are mainstreaming projects going on, warrant a mention, because we know that there are certain groups who, in addition to that kind of panel testing may also need counselling around the risk of other genetic syndromes, such as Lee-Fraumeni syndrome, warranting TP53 gene testing. And that's something that genetics would still be counselling for. And those were women under the age of 31, plus those with triple positive disease, as this lady was, because of a higher association of that pathology with Lee-Fraumeni syndrome. So as you can see, we've built up a management plan now for this lady that does include rather more than someone who perhaps was presenting in later life. She completed her neoadjuvant chemotherapy and went on to have a bilateral mastectomy, given that she also had DCIS in the left breast, and wished then to have a delayed bilateral reconstruction. She had a right axillary node clearance and she underwent right chest wall radiotherapy, given that she had an inflammatory breast cancer and therefore T4 disease at the outset. In the adjuvant setting, she completed her trastuzumab and pertuzumab, as she had a pathological complete response. And then we need to think about her endocrine treatment. Now, she's already on goserelin because she's had that through cytotoxic chemotherapy. And we know in these particularly young women from the SOFT and TEX trials that rather than just giving tamoxifen on its own in this premenopausal setting, that there may be additional benefits of giving ovarian suppression therapy, either with tamoxifen or with exemestane. Now, with each level of that additional anti-estrogen therapy, we know that toxicity, menopausal symptoms and impact on day-to-day life can increase. So there's always a balance of risk. And this is one of those areas where the guidelines around who we should be giving ovarian suppression therapy to are pretty broad. And most of the guidelines say, consider ovarian suppression therapy without any kind of real distinct risk factors that we should be giving it for. For her, she had T4 disease at the beginning and is under 35 and had chemotherapy. So is in that population that probably had the most to gain. On the flip side, she did have a pathological complete response. So we've got to keep that in mind when we're starting to think about how she tolerates this moving forward. But she was 33 with those risk factors, and she went on to goserelin and exemestane. So I then saw her about a year post finishing chemotherapy. And to me, I think she personified the challenges, or at least some of the challenges, of being in your early 30s and having had a breast cancer diagnosis. Sadly, her relationship didn't survive the breast cancer and the stresses, and her partner left. Her hair had come back grey, and this was then during lockdown, so she hadn't been able to go to a hairdresser's and do anything about it. She'd gained weight, so felt very, very different. She had stiff joints with a goserelin and exemestane and felt quite often, as people describe it, like they've aged quite a lot in a very short space of time. She'd had a bilateral mastectomy and hadn't had a reconstruction yet. So her whole body image was very different to when I'd first met her. We had to make a change. This was not tolerable. So we rolled back and we stopped her exemestane. We tried tamoxifen. That gave her a horrible vaginal discharge and awful hot flushes and sweats. We got to a point where we made the decision that actually this was intolerable. We stopped everything and gave her a complete washout of her endocrine treatment. And the cognitive decline, the brain fog, the mood, everything started to lift. We did dabble with seeing whether she could tolerate just tamoxifen on its own. And again, we just went straight back to lots and lots of endocrine side effects that made day-to-day quality of life intolerable. So eventually, after the kind of trial and error of what was going to work in terms of balancing risk and benefit, after a couple of years post-diagnosis, she's ended up on no endocrine treatment. And we know that that is a feature of ER positive breast cancer in the under 40s group, that actually compliance with endocrine treatment isn't as high as it is in the older age group, because some of these toxicities can prove so intrusive on day-to-day life that actually the benefits just just cannot be achieved because of the impact on day-to-day life. I'm going to move on to number 2. I'm slightly conscious of my timing because I do tend to talk quite a lot. So Jenny, please let me know if you need me to stop. This was rather a challenging case. This happened when I was about, I think, 6 weeks into my consultant post. This is a 39-year-old lady. She presents with a clinically 22 millimeters on ultrasound and mammogram, node negative, grade 2, ER positive, PR positive, HER2 negative cancer. She's 9 weeks pregnant. She'd been to see both a breast surgeon and an obstetrician, who both told her she should have a termination. I was contacted by a breast care nurse to say, Jo, can you ring her? Because she doesn't want a termination. Thank goodness. So we had a chat. Breast cancer and pregnancy. So within this half an hour talk covering breast cancer in young women, what I can't do is go into all the nitty-gritty of imaging and different chemotherapy drugs and all the evidence around breast cancer in pregnancy. But hopefully we can touch on it because, yes, breast cancer in pregnancy is rare, but you can certainly get clusters. And of all the people who present with breast cancer, if they're under 30, 10 to 20% of them will have gestational breast cancer because of the stage of life that they're in. So it's rare, but not that rare. And certainly within the first 2.5 years of being a consultant, I'd looked after 6 women with breast cancer in pregnancy. So, as I say, rare, but as a breast oncologist, it's something you will come across. So how do we approach this conversation with this 39-year-old lady who's been told she should have a termination? Crucially, there is no evidence that termination of pregnancy improves outcome. There is no evidence actually that pregnancy adversely affects the outcome of breast cancer matching for age and stage of the cancer. And that's one of the first things that women need to be reassured of. Now, that's not to say that for some women, termination won't be the right answer. This is a conversation that obviously needs to be handled incredibly sensitively, but for someone who perhaps has children before, has suddenly been diagnosed with potentially a very high risk breast cancer, well, actually for them emotionally, juggling everything, they might not feel that they can also cope with carrying on with that pregnancy. So it's still got to, that conversation's got to allow for the individual woman to express what's right for her. But I think it's really crucial that women understand that carrying on with their pregnancy isn't likely to affect their outcome from their breast cancer treatment. As I say, I can't go into all the nitty-gritty within this topic and the time frame, but this table just broadly outlines what we need to think about when we're then planning this woman's management. So can she have surgery? Yes, she can. Anaesthetists are probably a little bit on edge anaesthetising people in the first trimester, but actually there's no really good evidence to say that it proves harmful at any stage of pregnancy. So yeah, there's got to be caution, there's a little bit of nervousness, but still there's no good evidence to say that it's harmful to that developing fetus. What sort of surgery does need to take into account the stage of pregnancy that the diagnosis has been made, and what other treatments are likely? Because if someone's just going to have surgery in the beginning of in the first or second trimester and aren't going to also need chemotherapy, then their radiotherapy time-wise would fall in that pregnancy, and radiotherapy is contraindicated. So there is a high chance that women undergo mastectomy if they're pregnant because of the contraindication to radiotherapy. If, however, a woman has a diagnosis that means that she's going to inevitably have adjuvant chemotherapy or neoadjuvant chemotherapy that's going to extend through her pregnancy, and radiotherapy wouldn't fall till after the baby's born anyway, breast conserving surgery is still possible. Sentinel lymph node biopsy is possible, but they tend to avoid blue dye because less is known about that. It's more the sort of labelled contrast that's used, because there has been tests looking at the various doses of ionizing radiation, and it's considered reasonably safe to go ahead with that. Chemotherapy is possible. There's evidence of apparent safety of some of the most commonly used agents within breast cancer, of safety both for mothers, babies, and also there was a European study that looked at the outcomes for the children who were treated in utero with chemotherapy and looked at cardiovascular outcomes, development outcomes through childhood. And there was no evidence that they came to harm through being exposed to chemotherapy. A tendency that has been seen in what are largely all retrospective series of data is a tendency towards prematurity, so slightly earlier delivery and lower birth weight. So that's something to be discussed. There's some adaptations needed in terms of the supportive medicines that are given alongside that, and I've got a slide to just quickly summarise that. And it's important that the patients are weighed regularly and you dose it based on the up-to-date weight as that changes throughout the pregnancy. Endocrine therapy is contraindicated. We know that drugs like tamoxifen are teratogenic. We've talked about radiotherapy, and targeted therapies such as trastuzumab we know are harmful in the second and third trimesters. Safe in first trimester, and I think that's probably known about, mainly because perhaps people have been on adjuvant trastuzumab and fallen pregnant unplanned. So there is some data to say that if that does happen, it doesn't cause any harm. But in second and third trimesters, it is associated with oligohydramnios, which of course is very dangerous for the developing fetus. So it should be avoided if at all possible. So we'll go back to our 39-year-old lady, keeping this in mind. Should she be told to have a termination? No, there needs to be a sensitive discussion about what lies ahead. She really wanted this baby. She was 39. She might need chemo that then could render her infertile. This could well be her chance to have a baby. She's not going to let that go. So we talked about the fact that that wasn't necessary. We could still offer good treatment for her breast cancer within pregnancy. Yes, it would add an extra layer of worry and emotion and everything else, but this was manageable. With the features of her breast cancer, actually at this point, we didn't know that she definitely needed chemotherapy because we could do an oncotype to guide our management and the need for that. So she underwent surgery. It did prove that it was a 26mm node negative cancer, and she had an Oncotype DX score, which of course came back in the intermediate range. Just when you want a really high one, or not really high, but at least you'd know you were doing things with the right reason, or really low, it's in the middle. So this was rather a challenging conversation. Now, this is an extra layer of complexity because she's pregnant, but actually intermediate oncotype scores within very young women are a challenge all by themselves. So we've got data from the use of prognostic genomic signatures, both from TAILOR-X, which looked at the node negative population. We know in the over 50s, there was no chemotherapy benefit with scores above 25, no, below 25, of 25 and below, sorry, doing it the wrong way around. And below the age, below scores of 16, there's no benefit in anyone of chemotherapy, albeit the numbers of really young patients in these trials do tend to be pretty small. But in that intermediate group, there is some benefit potentially from chemotherapy. Now, there was the TAILOR-X study, and then Sperano et al. Published a further paper the following year looking at an interaction between clinical risk score and their oncotype score. They were defining a higher clinical risk as those with larger tumours, higher grade tumours. What they found was that in this younger population, so in the under 50s population, that in the higher intermediate bracket, the 21 to 25, actually there still looked like there was chemotherapy benefit of at least about 6% reduced risk of recurrence. And that increased if there was also high clinical risk factors. For the lower intermediate score bracket, the 16 to 20, with the low clinical risk, there was no additional benefit. But if those patients had particularly big or high grade cancers, actually there could still be a benefit from chemotherapy. And MIND-ACT, which looked at the MammaPrint molecular prognostic index, looked at 3 groups within their trial. They performed genomic signatures and tallied that up with clinical risk. If a patient had low clinical risk and low genomic scores, they just got endocrine treatment. If both measures of risk were high, they had chemo. And if there was a discord, low clinical, high genomic, or vice versa, then they were randomized as to which guided their treatment. That also very much tallied with the oncotype results and said, actually, if the genomic signature is low, even if there's higher clinical risk factors and the patient's above 50, there's no added benefit of chemo. But in the younger women, if they've got high clinical risk factors, even if the genomic signature suggests a low risk, there may be a few % benefit from chemotherapy. There is a note of caution to say a lot of this was subgroup exploratory analysis. So some of these subgroups were small, but it just puts that doubt that we can't apply the same fairly straightforward rules as we do in the postmenopausal population to our younger age group. And there's the further sting into the tail that actually within these trials, when women didn't get chemotherapy, the vast majority only got tamoxifen. And this is where there's then the theory to say, well, actually, some of this benefit might be coming from rendering these women postmenopausal. And some of that, in addition, comes from the fact that the people that seem to benefit most from chemotherapy with those intermediate risk scores were those aged about 45. So the people who are likely more at risk to develop permanent ovarian failure. The benefits weren't particularly there in the really young group. So even in a non-pregnant setting, these intermediate risk scores do require some weighing of pros and cons of different approaches in this younger age group. For our pregnant lady, we had an extra layer of complexity. And believe me, 6 weeks into a consultant post, I didn't just go on what I thought. I talked to colleagues in the centre, and we also asked someone who was considered one of the experts on breast cancer and pregnancy in the UK, and came to a decision together. She opted not to have chemotherapy. And soon after delivery, we started goserelin and tamoxifen. And we've gone on from there. And touch wood, she remains very well. And hopefully will continue to be so. How are we doing for time? This patient I'm going to go through very quickly. Those were my 2 longer-winded ones, so I'm going to keep these relatively brief. This is another lady presenting in pregnancy, 28, and a bit more typically for such a young lady with a triple-negative breast cancer. She was 20 weeks pregnant and had a 2-year-old son. We gave her neoadjuvant chemotherapy because the cancer was clinically about 7.5 centimetres. So we were quite worried that she was at very high risk from this cancer. The sort of extra considerations, yes, there's all the evidence about the agents, but the extra considerations in terms of planning her chemotherapy. We also want to think about fertility and genetics, as we've said, because of her young age and the risk of those things that may then impact on her further management. Now, fertility seems a daft one to put in here because she's pregnant, but that's actually something that we need to address. She is pregnant. She can't have fertility preservation. Now, this is her 2nd child, but actually the impact of telling someone that they're pregnant, they've got breast cancer, this chemotherapy might render them infertile in the future, and there's absolutely nothing we can do about it. It might actually feel hard. And yes, hopefully they will have a live baby at the end, but all of those plans and thoughts about what they might have wanted from their troop of children actually may be an extra element of psychological and emotional distress at their diagnosis, and shouldn't be forgotten just because the patient's pregnant and there's so many other things to think about. We've mentioned genetics. We now need to think about fetal health, and it's important to take a bit of an obstetric history. So I always want to know, well, what happened if you had a previous pregnancy? Did it go to term? I must admit, I almost fell off my chair when someone said their first pregnancy unfortunately resulted in a premature delivery. Fortunately, the baby was well, but at 26 weeks, which makes you very nervous because trying to plan for delivery then is very, very difficult. And you need a good working relationship then with that patient's obstetrician. So to know how that pregnancy is going, to know that they're going to be monitored appropriately, given that they're going to be on chemotherapy, and know what the plans are for delivery. Often we want them to go as far into their pregnancy as possible, because that's best for that baby, is to stay in utero for as long as possible. But we do then look quite often to induce the labour, because then we can plan chemotherapy around that to minimise delay in treatment, to optimise outcomes, but also to reduce the risk that someone's at the peak of myelosuppression when they go into labour. So there's planning to do with that. And then thinking about how you can time your chemotherapy. So for this lady, we normally give carboplatin paclitaxel, followed by EC. For this lady, I gave her, sit there with the calendar, gave her a 4 EC during chemotherapy. She got a couple of weeks of paclitaxel, which I always prefer to have the paclitaxel around the time of delivery, because there's less risk that if they do go into labour a bit early, of significant myelosuppression. And then I added, because she was only just into that second half of chemotherapy when the birth was planned, I added the carboplatin in as soon as she delivered, so that I was minimising the number of chemotherapy drugs I was giving during the pregnancy, but without compromising what we would normally do for her. And in terms of the supportive medications, actually many of them are reasonable to give during pregnancy. Aprepitant and the pegylated version of filgrastim we should avoid, and also it's preferable to give hydrocortisone as our steroid rather than dexamethasone, because it's metabolized in the placenta rather than passing through directly to the fetus. I'm going to, this one very brief, this is just one slide. This is number 4. So this just gives another example of a conversation that isn't that uncommon when managing and looking after patients with early breast cancer under the age of 40. So this is a lady who presented in 2016 with an early ER positive HER2 negative breast cancer. She had a really strong family history of breast cancer and was found to have a BRCA2 pathogenic variant. She underwent neoadjuvant chemotherapy, which was before my time looking after her, so slightly unusual given the biology, but actually she had a pathological complete response, and underwent surgery and sentinel lymph node biopsy. She went on to adjuvant goserelin and tamoxifen, given her very young age and hormonal receptor status. So this is the point of this story, is in 2019, she wanted to come to clinic to say, can I pause my tamoxifen? I'd like to have a baby. And this is obviously a conversation that patients want support and advice and guidance, balancing the risks of their breast cancer coming back against wanting to actually follow what they would like for them in their life and for their family. Up until recently, we've really only had retrospective data to go on in terms of guiding around safety of pregnancy after breast cancer. And whilst that's always shown that outcomes don't seem to be adversely affected, there's always been concern of that healthy mother effect, where actually it's only likely to be the people who have lower risk breast cancers, who are really well, who go on to conceive after breast cancer. The positive trial reported last year, I think it was at San Antonio, and has been published in the New England Journal of Medicine last month. And this is a prospective study looking at 516 women under the age of 42 who wanted to pause endocrine treatment in order to try to conceive. They were allowed into the study after anything from 18 to 30 months of endocrine treatment, and the median time was on that kind of upper border of the eligibility criteria at 29 months. So most people were waiting at least sort of 2.5 years before pausing their treatment. Still, most women did have stage 1 or stage 2 disease, but some did have stage 3 disease. And many of those women did go on and have at least one pregnancy. And again, a slightly lower number, unfortunately. Obviously, some of those pregnancies were not successful, but 317 of those women did go on to have at least one live birth. In the follow-up so far, looking at the 3-year incidence of breast cancer recurrence, they're looking pretty similar if anything, numerically slightly better in the group that did conceive, rather than the group that were matched, that didn't want to pause to have a baby and continued on with their endocrine therapy. So that is, I think, of additional reassurance to inform that conversation when patients are wanting to consider pausing their tamoxifen or whatever endocrine treatment they're on in order to try to conceive. And ending on a happy note, she now has 2 children. She plans to now go back on tamoxifen after her second. And because she's got a BRCA2 variation ahead of her now, she'll be planning towards bilateral salpingo-oophorectomy. So thinking about her future management, she's going to be at risk of problems with bone health, given her previous endocrine treatment and now a oophorectomy. And part of our job as well is yet not doing all the micromanagement of her bone health now that she's so far after a breast cancer diagnosis, but doing what we can around the lifestyle issues, cardiovascular and bone health, to help provide that kind of holistic advice. So in summary, I hope it's a bit of a whistle-stop tour of a few ladies that came to mind when Jenny asked me to do this talk, but hopefully it's highlighted some of the multiple issues for younger women who have a breast cancer diagnosis. Issues that are either unique to this population or perhaps have a greater impact for these women. The stage of life that they're at means that there are lots of considerations around pregnancy, fertility, plus those women with very young children trying to juggle all of life's challenges, and this adding in and also wanting to keep things as normal and as reassuring for young children that they may already have. Because of these issues, there is the potential for them to need extra psychological counselling support through treatment and beyond. And actually, I know that we're moving far more towards supported self-management and less routine follow-up. But there are many of these younger women who do benefit from continued support from the oncology team as they kind of come across various obstacles, challenges and stages of their life to get that advice and input given their previous breast cancer and treatment. And looking after younger women does sometimes require management with a wider MDT group, including some far more commonly genetics, fertility specialists, psychology, and sometimes gynecology with specialist menopause clinics for some of those really challenging menopause symptoms. And as I say, during the first couple of years of my consultant post, an obstetrician became a key part of my MDT group, possibly far more than I was expecting. As I say, a bit of a whistle-stop tour. This is just a few ideas for perhaps some areas of further reading. The latest ESMO guidelines looking specifically at issues for young women is published in the Annals of Oncology. The RCOG guidelines for pregnancy and breast cancer are there. They are quite old and I think are in the process of being updated, but again, gives a bit of an overview. And I found quite a nice overview as an ASCO population publication as well. And just if people are interested in that very recent positive study that was in the New England Journal of Medicine in the first week of May of this year.
That's right. And thanks so much for talking us through the literature and bringing those cases as well. I think the thought of giving somebody chemotherapy in pregnancy is still very nail-biting for me, but
it doesn't change. Even when you've done it a few times, it's still a very big relief when the baby is out and healthy and well. There's been, and so far, no more waters breaking on the chemotherapy unit.
Yeah, that is a good anecdote story, that which I've heard from you before. I think that that positive trial at the end there that you mentioned as well, hopefully gives people some hope about further children in the future as well, even after breast cancer. If anybody does have any questions, please pop them in the chat. But I'll start with a question for you, Jo, if I may, in terms of, obviously at the beginning you were talking about there being low numbers in terms of what evidence we have for treating breast cancer in young women, and do you think that's partly due to sort of access to trials and perhaps just us needing to encourage young women more to enter clinical trials, or do you think it's just purely the fact that the numbers are low because obviously it's rarer to have breast cancer in young women?
So I think there's a couple of factors probably. I think partly it's a feature of trials themselves, is there's a bit of nervousness that this is a higher risk population. And coming back to the kind of ER positive, HER2 negative genomic signatures side of things, trials like the Optimus study that we're still recruiting into for node positive women, it's an exclusion criteria. If you're under 40, that's an exclusion criteria. So some of it's in the protocol writing, the worry that perhaps that there's a nervousness to maybe omit chemotherapy for this younger population that we know actually have poorer outcomes. And then possibly a reluctance also of people who recruit. When you look at some of the oncotype studies and then the low numbers of women, of younger women going in, I don't know how much of that is driven by the patients that say, well, no, if there's any doubt, I just want the chemotherapy. And how much that is also professionals thinking, oh, this woman's actually only 29. Do you know what? We're not going to go down the trial. So I think there's probably a number of factors in trial design, us as professionals, but also young women potentially just saying, just do everything, even if the benefits might be small or it might be over treatment.
Great, thank you. I've noticed that there's a question come through on the chat from Dan Hughes. I don't know if you can read that, Jo, but Dan says, you mentioned that breast cancer in pregnancy is common, but not that uncommon. What is the best way for us as trainees to get experience or gain confidence in this, considering we may not come across it during our rotation in breast?
I think that's a really difficult one because it is it happens quite sporadically. So you might do breast cancer for 6 months, or it might be in your rotation for a year of your training and you never see it. I certainly hadn't seen or managed breast cancer in pregnancy through my training, and I did quite a lot of breast cancer because that's where I was headed. Yet in the first 2.5 years of being a consultant, I'd looked after 6 people who had presented in pregnancy. So it is a little bit, I won't say look of the draw, because that seems inappropriate that it's down to these poor women in that circumstance when you're doing breast oncology, having a breast cancer diagnosis. But it is kind of sporadic how it happens. I think there isn't a really good way to then prepare. It's then being, I suppose, the awareness of what support is there, and the fact that it is something that people expect, that if you've got someone who presents in pregnancy, that there is likely to be peer discussion, that even once you're a consultant, I don't think there's many consultants that I've come across who've had someone referred to them where they've not sat down with another consultant and said, right, this is the situation, this is my plan, these are the dates. And pretty much every time I've been presented with a lady presenting in pregnancy, I've gone back to the literature, reminded myself all of it, and before I've seen the patient, because I think it isn't a situation that even once you've done it several times sits comfortably, and I think it is difficult to know that you'll get that experience within training. So I'm afraid I haven't got any good answers. But I guess also teaching and scenario-based teaching to perhaps think about the nitty-gritty can be quite helpful. I knew someone was going to ask this question and I was dreading it. The IO, obviously this all happened before pembrolizumab. Now I have fears of pembrolizumab in the non-pregnant population, but in pregnancy, there's very, very little data. It will have been done. I've got to say, I would be very nervous about giving it. I think a lot of recommendations say don't do it. I think you'd have to really weigh up what the situation was. And again, I'd be going back to the literature and I'd be phoning a friend, I'd be phoning my IO toxicity colleagues to say, right, what's the data, searching the literature. If I was presented with this, but I knew someone would ask that. I swear, I was in the slides, I was like, I know someone will ask this. I'm not sure. I certainly don't know the answer. But it will crop up at some point, I have no doubt, over the next year. So
I'm sure, yeah.
Who will have to explore the literature on that. But I suspect there'll be very little evidence. And I think you'd have to be convinced that it's going to add a lot to diagnosis to go down that route and not try and buy time with maybe surgery. Well, mind you, you do surgery first, you could totally rule out the pembrolizumab. Yeah, I'm glad I'm not in that situation yet, and I'm sorry that doesn't answer your question more fully, but it's one that I would have to research heavily.
Dan had asked a further question
the national
about...
database. So yes, there was. I think this was something that was happening through the UK BCG registrars group that we were looking to put together. It was it was retrospective, but to try and collate the UK data in a bigger pool than what's often been single institution case series of breast cancer in pregnancy. So yes, but I must admit I don't know where that's up to, but that was a piece of work that had been started.
I believe that closing data collection next week, so hopefully we'll get the results of that coming through soon. Joe's referring to the UK Notch, which is the if people haven't heard of it, it's the National Oncology Trainee Collaboration of Healthcare Research, which is a bit long-winded, which is why they call themselves UK Notch. So have a look at that online if you don't know about it already.
No, that's fine. But you're right. In these rare situations, you do need to look on at things really on a national level rather than regionally or single institution. It doesn't really add anything. So you're right, Dan, to ask that question. But yeah, it's underway.
Great. I don't think there's any more questions on the chat. If I can finish with one final question. Obviously, the diagnosis of breast cancer must be devastating for young women or pregnant women, but either way, are there certain things that you always signpost these women to, whether that be literature, support groups, or anything online that you would recommend we advise our patients to go and have a look at?
So there are a lot of it will vary region to region. So in our region, there is a support group specifically for younger women. And I think that that's probably something that exists in pockets in quite a lot of areas, because I think lots of people come into the chemotherapy units and depending on the day they come and who's in, sometimes recognise that actually they're a lot younger than the people around them. So certainly in our area, there is a specific young people's group called Sam's Diamonds. So we let people know about that. There is a support group for people diagnosed with breast cancer online. Mummies something or other. I can have a little look at for that and let you know, Jenny. And to be honest, a lot of it is more individual support. And I think most people will take up the offering of counselling or psychology input when they're having to deal with pregnancy and breast cancer at the same time. The other resource that I tend to tap into is the lady that I talked about, I was quite worried about how she was coping with feeling like she desperately needed to do everything she possibly could to be there for the child she already had, and that was leading her to feel almost a bit detached from the child that she was expecting. And I was really worried about how she was going to cope with that, so I also linked in with the midwives to say, look, this is a risk, is the things we can tap into on the kind of postnatal depression bonding. So I suppose rather than lots of kind of communal sources of support, they are out there, and regionally, as I say, there are quite a lot of young people's support groups available. So it's finding out what's available in your area, but also thinking about the individuals that can support that woman on an individual basis, one-to-one basis.
Yeah, I suppose a reminder as well to add our midwives to that ever-growing MDT list.
Hopefully you won't need them very often. But again, they can be of support if they understand some of the issues from an oncology point of view. Yeah,
brilliant. Thank you so much. So I don't think there's any more questions. So thank you so much, Dr. Cliff, for presenting this evening. So thanks very much, and I hope you enjoy the rest of your evening.
Thank you, Jenny.
Thank you.
Thanks.
Bye.
Bye.